Hi. It is a great pleasure to introduce some analysis of medical consortiums in China. I'm Yan Chunzhang from the China National Health Development Research Center. Before I start, I want to say that the preparation of the report is led by Professor Qin Jiangmei from my department. And I will make this presentation on behalf of our research team and our center. The title is Medical Consortiums in China, Development Model and Typical Cases. And I think I will focus on typical cases, case time is limited. I think the background is very clear, and from the last session, we all know that the health expenditure is increasing fast during the past years. And ever since the beginning of reform and opening up in China, ever since 1980s, the medical service delivery system in China has increasingly become multi-tiered, diversified, and competitive. As during past several years, I stayed in Australia for my study. I know that if I want to visit a very high-level medical professional, I need a referral. But in China, I don't need to do that. So that means it's like it is in a chaos of service delivery. And I think in 2009, ever since the new health reform opinion released, a major aim is to establish an ordered healthcare delivery, ordered tiered healthcare delivery system. Many different measures have been taken, but it seems that most of them do not work. So the medical consortium is an important measure to address this challenge and this problem. In realizing this, in recognition of this problem, attempts and explorations has been conducted by the local and the central government. And we summarized the model for medical consortium into four development models. The first is medical service groups in cities, which is to channel quality resources towards the grassroots and share resources within the circle of influence. And the second one is the medical communities in the counties, with the integrated management of health institutions at the county, township, and village levels, and the coordinated service delivery within every county. And the third one is cross-regional specialist alliances, which is to expand service coverage and contribute to capacity improvement of primary care facilities. And the last one is telemedical collaboration networks. And among all these different models, the model of medical communities in the county is the most integrated and is recommended by the government. Therefore, in 2017, I think I will skip several of the slides to make it easier for your understanding. And in all these attempts and explorations started after 2009, and especially such as the most well-known Tianchang case was started in 2015. And based on all this pilot work, the central government released the policy in 2017, which is the guiding opinions on advancing the construction and the development of medical consortium in China. And researchers summarize four critical indicators of realizing consortium, which is called maybe four key performance indicators or four consortiums. One is on service delivery, and second is responsibility, and third is interests, and the last one is management. To realize all these four important, to achieve these four goals or aims, efforts has been made from governance structure, medical insurance payment method, and performance evaluations, as well as application of information technologies. As it is widely, sorry, I have to go back a little bit. As we talked about these 4 models, and there are different measures or policy articles that is listed for different models. And the model of medical communities in the counties is the most popular and like the most feasible one in China. So to define it, it is such a model is within each county. The county level hospitals will take the lead in integrated management of lower level health institutions in townships and the villages. Within the community, human resources, financial and material resources are managed in an integrated and unified way by the county level hospitals. And many different counties have explored these models. And the most well-known 4 counties or districts in China are the Shenzhen Luohu, Anhui Tianchang, Shanxi Quyang, and Zhejiang Deqing. So I will go to focus on this model and talk about the typical cases in China. And as we talk about these 4 key indicators, policy measures have been taken from these 4 aspects: governance, medical insurance, incentives, performance assessment, and applications. We want to analyze how these 4 areas take measures from these 4 perspectives. The first is integration of and innovation in governance structure. In Shenzhen Luohu, a single legal person entity is established by integrated the 5 district-level public hospitals and 23 community health service centers. So it is all these nearly 30 institutions is integrated like one institution. And in Anhui Tianchang, 3 county-level hospitals act as the leads of the 3 medical groups within the county. It's like 3 health institutions established based on the previous health institutions. Although at the township level, the township hospitals still retain their legal person status, and the incentives will be realized through performance evaluation based on health insurance, which will be talked later. And in Zhejiang Deqing, 2 county medical communities are established under support of provincial hospitals and linked to prevention and disease prevention and control facilities. And in Shanxi Quyang, as it is in China, the target population is only 50 to 100,000, so it is a small county. And all the health institutions are integrated into one independent legal person entity. And so the management of personnel, operations, assets, and medicines are integrated under a unified way. So that is the first aspect of policy measure. The second is the restructuring of medical insurance incentive mechanisms. So in Shenzhen Luohu, they implemented the global medical insurance budget covering hospital administrations. And the medical schemes in Shenzhen Luohu, the major 2 forms are urban residence insurance and urban employees, which are both applied and this measure. And in Anhui Tianchang, they mainly use the house insurance for rural residents, and based on a headcount-based prepayment system, both for outpatient as well as inpatient care. And in Zhejiang Deqing, they use the sum of medical insurance budgeted in full for every medical community. So there are 2 medical groups established for each group. So they use this global medical insurance budget for their use. And in Shanxi, Quanyang, still they use the global budget prepaid for the inpatient as well as the outpatient care. And for all the use of medical insurance payment, there is a rule of surplus can be retained within the community for them to incentivize their health staff and all the development of their institutions. So in this way, to improve the cost control as well as efficiency in service delivery. And the third policy measure is to launch and improve policy assessment. Different measures have been taken in these 4 areas, such as in Shenzhen Luohu, they mainly conduct the incentive mechanism for general practitioners, GPs, through an annual salary of 300,000 yuan in China. That is approximately 40 to 50,000 US dollars. And in Anhui Tianchang, they conduct this performance incentive through the health insurance surplus fund can be distributed among different levels of health institutions at a ratio of 6:3:1 on each layer of county, township, and village clinics, like distribution of this surplus based on their cost control, service quality, work efficiency, as well as patient satisfaction as performance evaluation indicators. In Zhejiang province, in Zhejiang Deqing, they mainly conduct a performance assessment through the reform of health insurance payment methods. For outpatient care, it is based on health count payment method. And for the inpatient care, for hospital admission, they conducted the DRGs plus the item-based payment method. And in Shanxi, Quanyang, they use a budget-oriented performance-based remuneration system according to the workload accounting. In all these 4 typical areas, the information system are all well developed, which is used for information sharing and communication, as well as to facilitate the resource sharing and resource communication, such as to provide expertise support from the big hospitals to primary care facilities during their outpatient care or inpatient care or difficult problem solving. So different measures has been taken. I won't talk too much on that. Although different measures have been taken, there are many challenges and problems exist at the moment. The first is that the public institution structure in China has a long history and very difficult to break up. The second is that we can see that case this consortium is established within a district or county, which is the basic cell or basic unit of financial management in China. Now, most of these cases, they place the responsibility of management as well as service delivery, service support to the county-level hospitals. However, in most county-level hospitals, the capacity of management as well as service delivery are not sufficient to show such a responsibility. And the third one is still, although we talk about these 4 consortiums of 4 key indicators, say the service delivery, the responsibilities, the interest, and the management. However, it is very difficult to unify, to integrate their objectives or interests together. And the last one, last but not least, is that the right and control of medical insurance payment, although conducted by the county, conducted by the Department of Health, the right and control of health insurance is not, do not belong to the county, and the control and rights do not belong to the Department of Health either. So these are all important, very major challenges that is stand in the way of achieving the goal of our medical consortium. And based on all these problems, I think we can, a lot of policy recommendations can be made. But maybe two important ones. The first is to specify the responsibilities and rights of different stakeholders, include the government, the health institutions, and external regulatory bodies. And the second is to align the medical treatment, medical insurance, as well as the drug administration system, include to improve the accessibility of drugs in grassroots institutions. That is basically a simple introduction of the medical consortium in China. Thank you.
All right, thank you. So let's take a few questions. Peter.
That was a very interesting presentation. Could you tell us a little bit, I think you're very correct to be focusing a lot of attention on the governance questions. Could you tell us a little bit more about how authority is shared or not shared between health insurance and the Ministry of Health and Medical Administration, if you will, at the national level, at the province level, and at the local level? Because I think that this is a problem many countries are encountering, how to try the kinds of things you're talking about when the governance structure is not well adapted to those kinds of changes.
So the question is the governance of the structure as well.
How is decision-making and authority, who has control over what between the health insurance funds and the government delivery system?
Let me answer for you.
Yes.
So the question is, what is the governance?
A little more, that's all I'm asking.
The question is, what is the governance structure in China in terms of, if you want to build this kind of integrated delivery system, who controls what decision rights? So I think the national, provincial, and the local levels sort of mirror each other more or less. So there's a newly created National Health Security Administration that is responsible for insurance. And so they would set the provider payment method for these integrated delivery system. So what she has been saying about how the insurance would pay the whole integrated delivery system one fixed budget, or based on capitation, or based on whatever, that's the insurance fund's authority. The insurance fund used to not be able to set prices. Fees are actually set by another organization, the Pricing Bureau within the Development and Reform Council. But that authority have now been integrated into the Insurance Association. Drug procurement, again, it is important to build an integrated delivery system, because for a number of years, the problem of building these integrated delivery system is that the primary care level actually are not able to procure the drugs that is required. So people go to the tertiary hospitals to get drugs. And again, that used to be another administration's authority. And recently, it has been integrated into the National Health Security Administration. So there's some integration happening.
And the provinces and the national?
So it's a parallel. So there's a parallel system.
Over these things?
Yes. So the province does have authority over these things, and even the municipal government have some authority over these things. Not the prices. The prices is more set at the provincial level. Then the Ministry of Health now is more responsible for the delivery system itself. So planning on which level of the facility should do what things, and so it's more of a traditional health planning strategy, that sort of stuff.
It's important to unpack that.
Yeah. And it is also related to, because in China, we mainly have 4 different kinds of health insurance, which are the health insurance for the civil servant, and the health urban...
Formal employee.
Yeah, for formal employees, urban employees, insurance, as well as urban and rural residents insurance scheme, as well as medical aid. So, I talked about this in these 4 typical areas. Mainly the insurance is based on the urban and rural residents insurance scheme. And only in Shenzhen, because Shenzhen is a new city, and there are a lot of employees. So the urban employees insurance scheme is integrated into this reform measure. And in fact, the earliest one, which is Anhui Tiancheng, is also the most well-known county in terms of this reform. It is started from the new usual medical scheme.
The rural scheme.
Yeah, the rural scheme. And
I think it's too much detail. They don't know all the details to understand that. I think the importance is that I think China is trying to push to set up primary care-based integrated delivery. The urban areas, I don't think there is any model that is working at all. So, in fact, if I would summarize, many of the urban models, the integration is starting from a big tertiary hospital, integrating downward. So what has happened so far is big tertiary hospitals is using the community health centers to basically attract more patients to them. So it's a market strategy. And so I asked her to present the several rural-based cases that seem to be moving more in the right direction. And so that's what she was trying to explain. Jack.
I want to emphasize the point you were just making, Winnie, which is to understand the performance of these systems, you have to look at the internal revenue flows across the different providers within them, not simply the external source of financing. That if the revenue center for the institution, either individually or collectively, is the hospital, then money will be sucked into the hospital. If the hospital is simply a cost center where you want to minimize the expenditures there, then you begin seeing shifts in where care is delivered. And that's dependent upon the internal flow within these capitated payments of the payments. So that leads to, so it's not just the external governance, it's the internal governance and financial incentives in the system that also need to be thoroughly explicated and understood. Which
is it being, I'm sorry, is it with a different mic? Okay, then I won't repeat.
That raises another question. We noted earlier in the earlier session that insurance is not paying for all care. You've got capitation in a number of these rural systems. What percentage of the care in the system is being paid for through the capitated insurance plan payments? What percentage has to come from elsewhere? Where is it coming? How is it being paid? And how is that influencing the decisions in the system as to which services to emphasize and which services to constrain?
Oh, well, I think that is maybe a little bit complicated.
So, Jack, you raised an excellent question. I think what happened in the first few pilots, the trouble is the even in a rural area where the integrated system is county hospital and then the primary healthcare centers, the payment is made in such a way that the hospital is still a revenue center. So they were attracting all the services to them. And some of the model that she was presenting, it is trying to turn the hospital into a cost center. And that's why she was emphasizing that for all the four models she's presenting, if there are savings, they can actually keep it. It is only when that happens, the hospital is beginning to try to get the primary healthcare center to do better and shift some of the services down. And I think that's what she was trying to emphasize. But what I think what China is facing right now is a bit challenging is you can pay this integrated delivery system a fixed budget, a fixed capitation, whatever it is, but internally, how they then redistribute that fund is actually a completely black box.
And I think in answering this question, because I think we learned something from the UK. The primary care facilities are steering up, say, the allocation of the resource flow. So, as a gatekeeper for the patients as well as the health insurance fund from the primary care to tertiary hospitals, secondary and tertiary hospitals. But now in China, from these four main models, we can also see that the county level hospital within this county, the county hospital is the head, right? In terms of techniques and resources. So such a model that is like the money in whatever payment method flow into this system. So it seems that the county hospital is taking the lead of resource allocation as well as management. It seems not the way of primary care. But at this stage, there are several realities. The first is that for primary care facilities, through all these years reform, the primary care is still weak. And the government is concerned it is not like powerful enough to show the responsibilities as gatekeeper for healthcare delivery. So it seems that within the county, it is a way to place this surplus retaining system, like that is the county to let the county hospital to keep the cost control and take the lead of expertise support to primary care facilities. So that is the reform at this stage. I think that is about the concept of the government design. Yeah.
Great, thank you very much. Let's move on to the next presentation as there will be comments later on. Julie.
I'll learn to wear this.
Do you want to wear it or do you
I'll
want
learn to wear it.
Change batteries.
Change battery.
I'm going to put this. Yeah.
Is it working?
I'm not sure.
Can you say
Can I?
something?
Sure. Test.
I think so. Yeah.
Can I put it here like this?
Yeah.
Okay, great. How can I find my... Here it is. Yep.
Yeah, we already there.
There. Yep. The next one. Yep.
Yeah.
So full screen. All right. Good morning, everyone. My name is Julie Shi. I am an associate professor in the School of Economics at Peking University in China. Thank you very much for having me here. In the opening, Winnie has raised several challenges the Chinese healthcare system currently faced. So in my talk, I will focus solely on the topic of drug overuse and try to push the topic a little bit deeper. So in my limited 15 minutes, I try to discuss the causes of the drug overuse, introduce briefly the regulations that has been implemented in China's healthcare reform, and show you the impacts of some of the regulations using an ongoing project conducted by my colleagues and myself, and finally discuss the directions of the future reform. We know that drug overprescription is a global concern. It's not only an issue in developing countries, but also in developed countries as well. Drug overuse is popular in the US, in the United Kingdom, as well as in other European countries. And we know that the drug overuse would bring lots of costs. Not only it would bring the side effects, the hospitalization, or even death, it would make a huge financial burden for the patients, and it's waste of resources, and it also would do harm to the environment. So in China, the drug overuse is severe. The problem is severe. We know that before the China's new healthcare reform, the antibiotics was prescribed twice as what is recommended by the WHO, and the rates of injection are 3 times higher than those in similar countries. The next figure, the figure shows the fraction of drug expenditures to total medical expenditures from 2003 to 2009, which is before the new healthcare reform. So you can see from the figure that for, how should I, like this? For outpatient care, the fraction is over 50%. And for inpatient care, it's between 40% to 45%. The purpose of showing the picture is that the drug overuse problem is really of great policy importance in China's healthcare reform. So that's why lots of researchers have researchers on this particular topic. Next, I'd like to, before I discuss the causes of the drug overuse, I like to provide some background information for Chinese healthcare system for those of you who are not familiar with it. And I hope it may address some of Peter's previous question. So in China, we know that China is a public system, that physicians are employed by the hospitals, and drugs are purchased in the hospital. Majority of the drugs are purchased in the hospital, both for inpatient care and outpatient care. We're discussing the topic of drug overuse. So in general, the problem could be induced from both the supply side and the demand side. From the demand side, we know that income increase, insurance expansion, etc. But it is widely agreed that the problem probably be mainly driven by the supply side, largely because of the information asymmetry addressed similarly by Arrow and by later health economists. So here, I will mainly focus on the supply side. In Winnie's openings, she actually already discussed some of the reason, the price distortion. So here, I just try to provide you a little more supplemental information on the price distortion. So one of the major reasons for the drug overuse is that prices of medical services in public hospitals are regulated by the government, are strictly regulated by the government. The government regulates the prices of services for almost all services except drugs. So including like tests, bed phase examinations, and medical materials. Here is a picture, is a screenshot from the website of the, here you can see the Beijing Municipal Commission of Development and Reform. From the reform, anyone can check the prices of medical services. Here I translated it into English. It can categories like emergency, community, preventive, and general. If we click the general, The next page will show you exactly the prices of different services. Here, oops. Here is some like different types of punctures and injections. It's 5 RMB per time. So that's the prices. So the one fact is that prices are regulated by the government. And also, Winnie has explained that the labor-related prices, the prices of labor-related services are underpriced, and the examinations and tests are overpriced. In the meantime, we also know that the drug sale could make up to 15% of markup. So drug is an exception. That's the first reason. Prices are regulated. The second reason is that the government subsidy only accounts for a proportion of a physician's salary. China is a public system. The majority of hospitals are public hospitals. Physicians are employed by the government. But the fundings from the central government to the hospitals are not enough. So hospitals have to perform as a for-profit firms in order to generate enough revenue to support the hospital. So then it is natural that prescription drug, become one of the most profitable and discretionary strategies for the hospitals to generate revenue. So I think that's the two terms work jointly to make the drug overuse a severe problem in China's healthcare system. The regulations in the reform, the government realized that the problem is severe, and since 2009, or even before 2009, there are like tens of regulations that has been implemented to try to control the drug overuse and also control the total medical spending, including like regulate the selling of the retail price, regulating the quantity of expenditures of drugs per prescription, the zero markup policy, and the most recent one is the 4+7 procurement with minimum quantity guarantee, which was implemented early this year. Due to time limitation, I will not go over it one by one, but I'm happy to discuss it during the break. The next one, I will use the rest of the time showing you the impacts of some of the regulations from the project conducted by my colleagues and myself. This work is the physician-induced demand evidence from China's zero market regulation and drug prices. It's a joint work with Professor Fang Hanming at the University of Pennsylvania, Professor Lei Xiaoyan, my colleagues at National School of Development in Peking University, and the last co-author, Yi Xuejie, is a PhD student at Stanford University. The motivation of the purpose is very simple. From the perspective of policy relevance, we try to evaluate the policy regulations on drugs. But also, the topic is interesting in academically. We know that physician responds to financial incentives in general. So in the US, there are tens of researches that have been conducted. Many of them would conduct the Medicare fee schedule change as an exogenous policy shock and see how physicians respond to these policy shocks, including one of Winnie's work conducted 20 years ago. And in drug use, it is also attracts several research on how physicians respond to the financial incentives in choosing drugs between generic drug and brand name. In China, there has also some experimental studies saying how the physician responds. In our work, we try to evaluate specifically the three policies on drug regulation. Let me introduce the policy background in a little bit detail. Before 2009, before the new reform, it is mentioned that hospitals, in all public hospitals, they are allowed to earn 15% drug markup. After 2009, things has been changed. In the following several years, price markup in primary medical facilities such as township community health centers and village clinics. So no markup is allowed for community health centers. However, in the meantime, in county hospitals and hospitals at upper levels, they are still can earn up to 15% of price markup. The second policy is the essential drug list. The central government implemented about like 300 drugs as the essential drug. The primary care health facilities are only allowed to price drugs from the list. The third one is the drug procurement at provincial platform. Before that, the price procurement is between the is directly between the hospitals and the firms. After that, the procurement is centralized at the province level. The three policies are implemented together. So we try to evaluate what's the impact of the policy on the drug use and the total medical use in general. For the data, we have the data for all residents covered by the new Rural Cooperative Medical Scheme, which is the largest public insurance program in a Western county in China. The sample includes 280,000 individuals per year, and we are safe to say that we have the sample covers almost all rural residents in the county. It's a medical claims data. It includes demographic information as well as spending and diagnosis information. So in our sample county, although the policy is implemented by the central government in 2009, in our sample county, the policy was finally implemented on October 1st, 2010. Specifically, in 18 township health centers, no drug markup was allowed. And in the 13 county-level hospitals, they can still earn up to 15% of drug markup. So in our analysis, we focused on the inpatient records and conduct the period from January 1st, which is the before reform, until September 30th, 2013, which is after the healthcare reform. As for the estimation strategy, it is a standard difference in difference estimation strategy. The pre, post, as well as the control and treatment. The control group is the county hospital, which does not implement the zero markup policy. And the 18 township health care centers are the treatment group. So this is the kind of like standard difference in difference estimation strategy. Before I show you the estimation results, here is a picture which I think shows the main findings of our analysis. So the figure shows the log of drug spending for township health centers and county hospitals separately. The red line is the time implementing the policy. So you can see that before the reform, the trend is kind of like parallel. After the reform, the county hospitals' medical drug spending remains almost the same, and there's like a huge decrease for the drug spending in township health centers. However, for total spending, it remains almost the same. And the findings supported by the estimation. We separate the spending to drug and non-drug, and then sum them together to total medical spending. So we can see that for drug spending, after the reform, there has been about 52% reduction. For non-drug spending, there has been increase about 33%. And for total spending, no significant change. So the message delivered to us is that although there has been huge decrease in drug spending, it seems it's all substituted by the non-drug spending. That's our main finding. We also show the spending per admission by categories, including like tests and examinations, infusion, bed, nursing care, and materials. The conclusion is that if more discretionary services has a larger increase in spending increase, or how to rephrase, spending reduction focuses on, spending increase focuses on discretionary services. That's to say, examinations and tests are more discretionary, and the stay in the hospital one more day is more discretionary. So we see a higher increase for them. And for example, medical materials and infusion. See, I'll finish it in 1 minute. So they remain almost the same. And next one showing that whether the result is created by the switching of patients between county hospitals and township healthcare centers. We conduct several robustness checks and find that that's not true for the case. All right, we also conduct some healthcare outcomes using readmission rates and check the inpatient days and find that there's no significant outcome for no significant impact on healthcare outcome in using the readmission rate as a measure. I skipped the conclusion, and the final slides is that the government target is to set appropriate should be set appropriate incentives to hospitals and the physicians instead of solely implement drug regulations to control the drug problem. So set the right proper incentive and the right system should be a target. And the ongoing regulations, for example, the payment system like the DRG, the paper forms, or even the capitation, and also public hospital reform like remuneration, allow the multi-site practice, and also the medical price reform would also help to contend with the problem of drug overuse. That's all I have. Thank you.
Well, just one burning question, Rachel.
Yeah, so for the drug expense, it's really the money paid by the insurer, right? So does that take into account out-of-pocket drug spending by the patient? Because, I mean, provided possibly it should cost to the patients, even though there's zero markup, but they probably can ask the patient to pay out of their own pocket. There incentive to the providers to do so.
Yeah, that's a great question. So the question is, spending accounts for the total spending or no, the out-of-pocket spending or spending reimbursed by the insurance. So my reply, there are 2 points. One is that the spending here in our analysis is the total spending. It includes the out-of-pocket spending as well as the reimbursed amount from the insurance. But I think Rachel's question involves another issue, is that whether the question comes from the, could also comes from the demand side, because the zero markup would affect the price of the drugs. So the demand, so the out-of-pocket so the price faced by the consumers may also affect the equilibrium. So is it a question? Yeah. Yeah. I think I'm going to raise a question. So the reply was that because the price would go down after the implementation of zero markup policy, the demand would go up. However, in our analysis, I don't have time to show you more details. We find that the quantity goes down. So that's the opposite of the direction from the demand side. So that's why in our analysis, we shape it as a physician-induced demand instead of the demand side change, etc.
Okay. One other question, maybe?
I guess one thing after time, as I understand, there are other public hospitals. I'm not sure if that happens in one particular county. That might help explain why we see that when drug expenditure goes up. We have a very big different different counties we find that. The other thing is based on basic health reporters. I'm not sure if it's really comparable between the township level versus county level. I see from your figure it looks similar, but I think ideally you probably be much better if you have this.
Thank you. 2 questions. One is that whether in the recent are there any other reforms conducted in our sample county. The reply is that there might be, but we have tried our best to search for the government documentations, as well as we visited the county and have talks with the officers, and we don't find like a huge change in the policy during the period. And also from the figure, we can tell that it seems the change taken immediately or like shortly after the implementation of the drug reform. So we believe the impacts, we hope, largely driven by the implementation of the drug regulations. For the second, shall I address the second question?
Yes.
Okay.
We're running a little bit short of time, so let me just keep moving to the next presentation, and there will be plenty of time afterwards during the comments.
Okay, thank you.
Do you want to wear it or do you want to hold it?
Am I correct? Good morning, everyone. I'm Pan Jie from West China School of Public Health, Sichuan University. There are three main reforms in the delivery system in China in the new round of reform. One is talk about the integration reform, and another is payment reform. And I will talk about the another reform is a market strategy to encourage the private hospital development in the delivery system in China. My talk is about on the association of the market mix of the hospital ownership with the medical expense. We have chosen 1.2 million inpatient samples of 44 representative diseases in China. Xue Qingping and Wei Li are the co-authors for the research. My talk follows the 4 parts. Here is the motivation. As the last presentations mentioned, the Chinese government launched the new round of national reform since 2009, 10 years before, in order to defeat the long-standing social problem. Getting the medical care is too difficult and too expensive. In this reform, one of the main policies put forward is to facilitate the private sector development. Since the reform, the State Council and the National Health Commission of China have been issued more than 20 national policies to facilitate the development of the private hospitals. We have selected, shown some of them here in the table. These policies, including relaxing the market access restrictions, providing preferential tax policies to private hospitals, also putting the private hospitals on equal footing with public hospitals in terms of social health insurance program contracting, health science research, and so on. Followed by them, a series of companion implementation policies by local governments have also been enforced. Under this context, the private hospitals expanded rapidly than ever before, as shown in the bottom figure. The blue line represents the share of private hospital number in total, while the orange one for the share of private hospital beds. Both of them doubled since the reform. It should be noticed, although the total number of private hospitals has already exceeded the public since 2015, the average private hospital size in terms of hospital beds are relatively smaller than public. The policy for facilitating the private hospitals' development is mainly designed to enhance the delivery capacity and fuel competition in healthcare market. The private hospitals are not only encouraged to provide the high-end and most advanced services, but also the basic health care as a supplement of the public hospitals. The growth of private hospitals serves a potential market strategy to intensify the competition within the hospital market. Higher degree of competition would lead either of private or public hospitals to improve their efficiency and control operating costs, that in turn to lower down the medical expenses. Addressing the problem of the getting medical care is expensive. However, some opponents argue that expansion of the private hospital would further escalate medical costs. Facing with a higher degree of competition, the provider would utilize the widespread unique characteristics of the healthcare market, such as information asymmetry, to induce the patients into unnecessary services. Moreover, like the medical arms race might be initiated by the new private hospitals, the expensive, up-to-date, and high-tech medical equipment would be sought in order to signal their quality of care to attract patients. But the increasing cost would pass on to the patients, lead an increase in medical cost. Confronting with this dilemma, though a rich international literature evaluate the healthcare outcomes between the public hospitals and the private hospitals, but only few of them explore the association of the market mix of hospital ownership, or we can say private hospital market share, with the medical expenses. Here we listed two studies we found. One is from the United States. Kessner utilized cohort data, finding the growth of for-profit hospitals in the market had the potential to decrease the medical expenditures in among AMI patients. Gordon and his colleagues utilized provincial level data in China from 2002 to 2006, roughly just before the national reform, had found that increasing for-profit private hospital market share would lower down the total medical expense per patient. Considering these polarized arguments for the expansion of private hospitals, but limited evidence, our study aimed to evaluate the association between private hospital market share and the medical expense in China 7 years after the national health reform. This study would contribute to provide more evidence on the association, as well as to assess recent development of the private hospitals in China. Okay, here we move to the data and method. The data area is the Sichuan province. We choose Sichuan as our research area, mainly for the data accessibility. Meanwhile, the disparities in economics, population, and geography within Sichuan are similar to the whole China. Upper left figure shows the Sichuan province location. The green region is Sichuan, a southwestern province in China. Upper right represents the elevation in the province. West Sichuan is the plateau, connecting with the Tibet plateau, while East Sichuan is a plain and hilly area. In the bottom right figure, we can see the population distribution highly coincides with topography. East Sichuan has a relatively higher population density than the West. Bottom left shows the county-level GDP per capita within the province. Since the local health care development tightly associates with economic, social, and demographic factors, there are great variations in the private hospital development among regions in Sichuan, which providing us a particular opportunity to identify the relationship. The data we used come from two sources. First, the Health Commission of Sichuan Province provided both inpatient discharge data and administrative hospital data. The discharge data comprehensively covered information about each inpatient who was admitted to hospital located in Sichuan Province during the fourth quarter of 2016. The administrative hospital data include the basic information of each hospital. Second, we G-coded the hospital address and get their longitude and the latitude information and incorporating them in the GIS system. In order to control the heterogeneity of diseases, our analysis is based on single diseases. To maximize the generation of the results, we include the most common diseases, 44 representative diseases in total. The observations are more than 1.2 million inpatients, which are counting around 45% of the total inpatients in Sichuan Province during the study period. The main outcome variables are the total medical expense, as well as the out-of-pocket expenses and the reimbursements by the social health insurance programs. The key independent variables is the market mix of hospital ownership. We firstly define the hospital market by employing a fixed radius approach with a radius of 15 miles. Then, within the market, we calculate the share of inpatients treated in the private hospital for each disease as our measure of the hospital market mix of the hospital ownership. We estimated the relationship by multiple log linear regression models. All models were adjusted for a series of co-variables, including a set of patient and hospital characteristics, such as patient age, gender, occupation, type of insurance program, length of stay, the condition at arrival, whether public hospitals, hospital level, type, and so on. Now we move our results. Here are the descriptive results for each disease. All the diseases are sorted by the total number of inpatients in descending order. All of our results will follow the same rule. Both of the medical expenses and the private hospital market share vary, of course, among the diseases. Okay, here shows our main results, illustrating the relationship between private market share and the medical expense, adjusting for all the co-variables. The estimation in red color indicates there is a statistically significant and negative association. The blue indicating a significantly positive association, while the green color indicating no statistic significance. The association for 17 diseases among the 44 diseases are significantly negative, while only 7 diseases are significantly positive. It is very interesting that in the first half of the diseases list, in the first half, 22 diseases, there are total 44, but in the first half, 22 diseases, 14 of them are statistically significant and negative. Only 2 are positive, showing for the most common diseases, the private hospital development associates with lower medical expense. Among the 7 diseases which have significantly positive relationship about these 5 diseases, both of them are related to the bone fracture. We further explore the relationships between market mix and out-of-pocket expense and the reimbursement. This figure shows the results for the out-of-pocket. More interesting, most of the diseases, 25 out of 44 diseases, shows a statistically negative relationship, showing higher private hospital market share associates with lower out-of-pocket. By contrast, the association between the private hospital market share and the reimbursements shows a reverse trend. Increasing private hospital market share correlates with higher reimbursement for 33 diseases. In order to address whether there would be different responses to private hospitals share between public and private hospitals, we further explore the interaction effect of private hospital market share and hospital ownership. This figure illustrates the estimations of the interaction term, showing heterogeneous relationship between ownership among diseases. But most the public interaction term shows significant and negative estimations. We also conduct several sensitive analyses, including an alternative measure of private hospital market share, as well as quintile analysis. The results are robust, not sensitive to the measure and the different quintiles. Okay, discussions. First, our results show the increase in private hospital market share associates with lower medical expenses for most diseases, providing new evidence to support the policy to encourage the private hospital development in China. Second, the increase in private hospital market share correlates with most of the diseases out of pocket, playing a significant role in relieving patient economic burden. As the out-of-pocket is directly perceived by the patients as a favorable market strategy, the hospitals would like to decrease out-of-pocket while increase the reimbursements. The potential benefits of encouraging the private hospitals may result from adoption of similar strategy in other developing countries. Okay, that's all. At last, I would...
Okay. We're running a little bit out of time because people talk too. And let's just ask one question, and I think we need to move on to the last presentation, and we'll do the commentary together. How about I'm trying to take people who haven't asked a question.
Might be another limitation is that for public hospitals, if they are dealing with more complicated cases, these comorbidities, they might admit those with severe morbidity comorbidities. And in that case, then their medical expenses might be higher. And they might send back those with less comorbidities back to the lower level hospitals. Now, if that's true, and if you want to test that, you might be able to control it for that if you can indicators of the comorbidities.
Okay, thanks, Adam's his question is that because in China, the public hospitals have higher capacity for treatment, so maybe there are patient selection between public hospitals and private hospitals. That is, patients treated in the public hospitals would be have more complicated diseases or standards. So for your question, my answer is that because our dependent variable is the medical expenses on average, not only for the private hospitals, but also for the public hospitals. Second is that for the co-variables, we control for the for the patient's status at arrival. Also, the comorbidity is also controlled. Okay.
Thank you.
Okay.
It does look good. Okay, yeah. Good morning, everyone. My name is Hu Min. I come from Fudan University School of Public Health. It's my great honor to be here and introduce briefly to you what is going on in the pilots of the long-term care insurance in China. So, as we all know that China has a very rapid demographic transition and is aging at an unprecedented rate. The projected functional disabilities of the population in rural and urban areas suggested that there is actually a very high need for long-term care. And it should boost our thinking about the future system of the long-term care. So given the demographic and the socio-economic trends, actually there is a large gap between the long-term care demand and its supply. So in recent years, the government as well as the society put lots of efforts in building up the infrastructures of the aged care. However, the utilization rates of different institutions are not as high as we expected. So among the various reasons, financial gap might be one of the leading ones. So worldwide, the main financing approaches to long-term care remain in three kinds of the approaches. One is mandatory social insurance system. The other is that tax-based universal system. And also, in some countries, there are private insurances. So in 2016, China initiated its long-term care insurance, social insurance pilots in 15 cities. And the central government sets clear policy directives while encouraging the local governments to pilot the innovative ideas. So to understand what is going on, what is the long-term care insurance arrangements, we were planning to visit the 15 cities, the pilot cities. And at the first stage, currently we have visited 5. So today, my presentation is based on the findings and the reflections based on these 5 cities. They are Shanghai, Suzhou, Qingdao, Jingmen, and Chengdu, which covers the east and the middle and the west part of China. So as the social insurance is actually the financing arrangements of the long-term care, so I adopted the WHO's framework of financing, which defines financing into 3 main functions, which are revenue collection, pooling of resources, and purchasing, to describe what is going on in the long-term care insurance pilots. So the first question is, how is the revenue collected? As you all know, or as you may know, there are actually two main kinds of insurance systems in China now. One is for the urban employees, which is called UEBMI for short, and the other one is for the residents in rural and urban areas, which is abbreviated as URRBMI, and both of them are actually achieving the universal coverage. So the long-term care insurance currently covers the enrollees of these 2 kinds of medical insurances. So more than half of the funding of the long-term care insurance actually comes from the existing two kinds of medical insurance pool fund. And another main source of the funding comes from the government subsidies. The enrolled individuals made their contributions through the existing personal saving accounts of UEBMI or by out-of-pocket. But at current stage, the contribution in forms of the out-of-pocket are usually exempted. So, and also the employers currently do not make a contribution additionally, but since the pooled funds of the UEBMI are actually mainly collected from the employers, so in this sense, we can say that the employers are also making contributions. Okay, sorry. So here is the table that summarizes how revenues are collected in the 5 cities. And we can see that...
why don't you skip the detail of
okay, just one sentence. Actually, we can see that the premium per capita per year ranges from 80 to 280 in 5 cities, higher than that of the residents in all the cities. So in terms of this mechanism, there are at least 3 challenges to the mechanism of the revenue collection. The first one is that currently the financing of long-term care is highly dependent on social medical insurance, which actually made the rationale and the relationship between these two kinds of insurances are very unclear. And it also poses more challenges in those areas with less surplus of medical insurance. And secondly, since that China's economy slows down, and whether the government could sustainably invest in long-term care as they did in the medical insurance system remains unclear. And thirdly, the problem remains in the people's willingness to pay, because actually currently the people do not really pay by cash, and since the benefit eligible rate only about 3%, among 1,000 population, so it is it is actually a very big challenge that people are willing to pay for the very low probability for the future disability. So the second question, or the second function, is how are the resources pooled? Actually, the 5 cities have very various population, but the level of pooling is also different. We can see that there are 2 cities actually pooled at the municipal level, but the other 3 cities are pooled at the municipal level, but the other 2 are actually pooled at a lower level and with much less population inside each pool. And also, some cities put the employees and the residents into one pool, but others actually separate them into 2 pools. So this one actually raised the questions of the vulnerability of small funds, and also separate funds for the residents and the employees. On one hand, actually weakens the risk pooling mechanism, and also brings in equity issues. So the next function is what are the purchasing arrangements? The next few slides, we will cover them in details. So currently, the government offices of the municipal and the county healthcare security and administration are responsible for making policy decisions of the long-term care insurance, and can be seen as the purchasers. At the operational level, there are public agencies, 1 or 2 public agencies. However, due to the insufficient capacity of the public agencies. They actually contract out their services to the commercial insurance companies. So the work contracted out, including managing the long-term care providers and doing some like organizing need assessment and reimbursing the users, as well as communicating with the public. The contract terms are various among these cities. For example, in Suzhou, actually the insurance companies, they bear most of the financial risks. And in Qingdao, they borrowed some employees from the insurance companies and paid the salaries. And in Jinmen, insurance companies are paid for their operations. And in Chengdu, the payment is tied to the administrative performance. So for whom to purchase? Actually, in different cities, most of them made their own tools to assess the needs. So the activities of daily living are universally considered among all of these cities. And the IADL's sensory disability, cognitive disability, and social involvement are taken into account in some of the cities. In Shanghai, age and disease are also considered as one dimension of for the eligibility. So the long term is defined universally in all these cities as the duration of disability more than 6 months. And so after the assessment, the disability level or the care level is defined, and the eligibility decisions are made based on the levels of disability. And the purchase these in-kind long-term care services from the healthcare facilities and the aged care facilities. And also they buy community-based or home-based services from the professional organizations. But in 2 of the cities, actually they covered home-based services provided by the individuals, which means that the family caregivers or the family members or the relatives or the neighbors, their services are also included. So what to purchase? The services purchased can be broadly divided into 2 categories. One is called the nursing care, the other is the daily living assistance. So there is actually a wide variation among these cities. For example, in Suzhou, only those, the insurance only covers those predefined items in the category of daily living assistance, but rather than the nursing cares. But in Qingdao, the nursing care are actually massively covered, and the items in the daily living assistance at the professional facilities are not limited. So in terms of how to purchase, currently the purchasers pay the providers by fee for service, or fee for per diem, or fee for per hour, or per month. So and ask the users to co-pay, and the purchasers actually control their own budget, own cost by setting the fixed rate of payment or the ceiling of the benefit. And actually, this gives a chance to the providers to balance billing from the patients or from the users. So it is a common case that the providers increase the price when the users get the reimbursement from the insurance. And also that in terms of different types of the services, the purchasers actually give priority to the home-based or community-based services, as the home-based services usually has a higher rate of the payment or has a higher benefit ceilings. So we can see that usually a user of the most severe situation, they can get around $1,400 to $2,400 per month from the insurance. So the challenges remained in purchasing is that actually there is a variation in eligibility criteria and the benefit packages. This actually gives a rise to the equity concern. And secondly, the purchasers do not have enough controls over the providers because they seldom select the providers, especially with the intention that they want to develop the industry through the insurance. And the second one is that the purchasers actually seldom set the standard guidelines for the care they purchase. And this made actually the service provision are very the service provision are not standardized. And also the per diem or per hour reimbursement or payment mechanisms actually incentivize providers to provide less. And then it cannot control costs to the patients or to the users. And last but not the least, actually, little attention has been paid to the quality, and it is really difficult to monitor what is going on in the provision, especially those services provided by the family caregivers. So, based on our observations, we have some policy implications. We suggested that at this moment, the sustainable financing mechanisms need to be considered, especially based on figuring out the relationship between medical insurance and the long-term care insurance. And the secondly, in terms of the resource pooling system, we thought that the fund is better pooled for the employees and the residents together and as the one system and better at a higher level. And the third one is that the purchasing arrangements are far from strategic. Given the experience of the medical insurance system, we suggested that even at the early stage of the establishment of the long-term care insurance, the measures need to be taken to enhance efficiency and the quality of care, as well as the equity to access and the benefit. So that's what I have. Thank you very much.
I think we're just going to invite the remaining commentators. While you comment on the paper, also draw the implication on other Asian countries as you have planned, and then Peter and Ajay can add whatever you have not said. Doesn't matter.
We'll pass the mic.
Here, why don't we let you two because, yeah.
Follow the paper order?
Yeah.
Okay. Yeah, yeah. That's what my first question, whether we want to join.
Second, right?
Hello, is okay? Yes. Okay. Hello, my name is Hong Wang. I'm a senior program officer at the Bill and Melinda Gates Foundation, as well as a professor at the University of Washington, based in Seattle. And thanks, Winnie, for organizing this wonderful session and invite me as a commentary for these two very interesting and important research. So I used to be, as Peter mentioned, he was a long-term observer for the health reform in China. I used to be the participant of the China health reform in the early stage. I left the country for 20 years ago, but I can see many of the topics you're discussing was kind of, some was we didn't mention about before, but a lot of we actually trying to address and struggling with. And I'm very glad to see that a lot of progress has been made in over the last 20 years. And the first paper I'm going to comment is about the medical consortium. I used to actually working in the institution that you've been working right now. And at that time, most of our focus is on financing, how to raise sufficient money to cover the essential service. Now I'm very glad to see the research right now extended and the policy extended to the service delivery issue, which is once you have money, how are you going to use that to efficiently, effectively, and equitably, which is a very important topic. I see I've been observing those medical consortium for quite some time, and I think the research is very interesting. A couple of comments I would like to raise is, first of all, I would want to be more focused on the objectives of this medical consortium. Like when you mentioned, some of this consortium is really for marketing penetration purpose, right? So it's a marketing strategy to getting more patients to my institution rather than serve the objective of social objective, which is make service more affordable, accessible to the people. So we have to think about to look at all different type of consortium. What's their objectives? What they want to achieve? The second one issue is about decompose what they're really aligned to, what they're really combined with. So the integration you mentioned about, whether those services are integrated. For example, one of the major challenges in China service deliveries is separate between the preventive service versus the curative service. So whether those integration really bring those things together. And especially given the current epidemic, the disease patterns, we have to think about bring those two type of service together, and whether this integration model really solve this problem or not. The second one is about a team-based care, because given the complexity of the service, you're not able to just deal with all these complex service with a single providers. And normally we can see in the fragmented system, people and the patients actually have to chase provider all over the place. And now with the integrated model, whether the system able to chase patients rather than patients chase providers, which is a very, very critical component for the integration of the care. The third one is about the governance issue that Peter mentioned. It's very, very critical. I mean, who really has the power in this integration model, right? So a lot of power right now is still controlled by the hospital rather than by a lot of primary health care, by the lower level of, so imagine what's the decision going to come out from this integrated model. I remember in the early years when we trying to learn from a UK model about their reform, and before their reform back to the 90s, and the power was controlled by the hospital. And every year, the GP has to send a Christmas card to the hospital providers because they are their teachers. They respect them. They have to transfer their patients to the hospital. But after reform, when they developed the GP fund holder, the Christmas card direction changed. The hospital started to write a Christmas card to the GP fund holder because they hold the money. They make a decision if they decide who they're going to send to in terms of. So who has the power? Who really make a decision in that consortium is very, very critical. And the first one, you actually, the fifth one you mentioned about the financial incentive, which is also very critical. I saw some of the model is trying to address those issues. I knew the Kaiser permanent model actually made a huge influence in a lot of this consortium development, which is in the right direction, but how to decompose and analyze those issues. The last one, but not least one, is information fragmentation. You can see this integration of the system, and people, when they go to the village doctors and go to township and go to hospital, the information are not shared each other. So you have to do the repeat the examination, repeat the consultation, and everything. But all of this fragmentation are we able to address by those newly developed consortium, which is very, very critical. The third issue I want to raise is about the result. I think it's an early stage about this medical consortium. We haven't got much of the result yet. And whether we are able to reduce bypassing of primary health care, whether we are able to address the two-way referral system. Right now we can see always one-way referral system to the up. Right, so, and whether we are able to reduce avoidable hospitalization and control the cost, and whether we are able to really solve the quality of service issue. There's a lot of the issue is unanswered. I honestly to say is in a very early stage. The last question I want to raise is, what's the lessons we can learn from our financing reform? To relate to this delivery reform. And recently I brought an India team come to China to learn about the financing reform, because India just announced their multi-care. They developed their insurance to cover the poor. And they want to learn some lessons and experience from China. They learned quite a lot. I want to raise a positive side, but one astonishing part they found is the fragmentation of our insurance system. We went to one hospital, the Wuhan tertiary hospital. So they're facing multiple types of patients. And some patients is from provincial level. They have their own benefit package with one ceiling, one co-payment, and one payment mechanism. So they developed a mechanism to pay this type of patients. Then they have a city population. They have their own unique benefit package with different ceiling, different co-payment, different deduction point, and so on. So they have another system to deal with. And then you have a rural insurance, you have a city residence. So each insurance, although we summarize one or two insurance, but each of them are very unique. And the hospitals are swamped by those fragmentation of the different type of insurance with a different policy. And here is again, it's happening on the delivery side. We're going to have so many different consortium. What's the policy guidance from government at the central level to harmonize this, reduce administration costs, to address those issues from the beginning of this fragmentation is very, very critical. So that's the first paper. The second one is drug markup paper. Again, very excited. I have to say, I'm actually one of the person actually helped design this policy back to 1994. Right? We actually proposed this question to say, can we remove drug markup and control the cost, but with some of the cautious, which here we found. I remember early stage that Bill Shell from Harvard mentioned, it's like a balloon. If you squeeze a part of the balloon, other parts going to blow up, right? So when we try to reduce and trying to control the cost of drugs, then the other part of the cost increased. You eventually have a zero-sum games. Here we are, we found some interesting result. which gave us some kind of an indication when we develop a policy, we have to think about the consequences. We have to think about those consequences in advance. Rather than deal with them afterwards, right? So that's our research and our policy advisors should be functioning rather than address it afterwards. Couple of technical issues I want to raise, and certainly one of the issues raised by our audience is you're comparing between township hospital versus county hospital, whether it's comparable, how do you control that? Because the patient profile is quite different. Technology is very different. I imagine probably township hospital probably are much more rely on drugs than county hospital, given the sophistication of the technology and the patient's profile. What's the potential bias if you use that county hospital as a control group? The second one is you mentioned about one of the benefit, the potential benefit from this drug mark is actually the quality of care didn't reduce. One of the indicators you used is the longer stay in hospitalization. I doubt it can be interpreted as a quality issue, because it could be a strategy of cost remedy, right? So it could be a low quality issue, because the low quality you have to stay longer. So be careful about the interpretation about the result. And the last one is about certainly we can see in your early presentation you mentioned about actually the outpatient service share much larger share of has a larger share of drug. And so what's your study, how you use this study infer to about outpatient service? What's the relation between that? If we apply this policy in outpatient care, what's going to happen? What's the elasticity about this of this reaction in terms of this policy? Again, it's great work, and glad to see at least we can see some results and draw further conclusion and the implication for the policy. Thank you.
Why don't you go ahead? No? Me? Yeah, the paper. Oh, okay. Well, Winnie asked us to not only concentrate on a signed speaker, but also just briefly comment on other papers. So yes, for the two other papers, my only comment for the hospital consortium is to advise. Since your presentation didn't really talk about assessment of their performance at all, you're just talking about how the consortiums are constructed. If you read the State Council policy documentation for this policy, there was a cautionary note in the government documentation asking that this policy should be treated with caution, not to have big hospitals to expand their territories by integrating local small animals. So that's the one, warning note in the government paper. So if you're going to do an assessment of their outcomes, I think that's something you should always keep in mind, because we have heard a lot of stories about those pilots where they really didn't do as what the policy intended to do. Okay, so that's just one quick note. For the second paper, I agree with you. Julie, you have done a great job by applying econometric skills to tease out the impact of zero markup policy. I think they are all right, because your two groups are, again, two different animals. county hospital versus the township hospitals. As you introduced in the beginning, they were given very different policies at least in the beginning of the reform. So I think that's something you're going to deal with, because everybody has that concern. Okay, so those are two quick comments for the first two papers. Now for the third one, which is I'm supposed to comment on, I'm really happy to see how Jay and his colleagues come up with some results showing one central message: competition does matter. Even in the healthcare field, where people are skeptical about the role of competition, but the matter of fact is, if we follow empirical evidence, the competition still does good job than otherwise. If we discuss the role of private sector competing at a conceptual level, I think we can never end with any consensus. So empirical data got to be something we have to all rely upon. Now, I like to point out one contribution you really made in this study beyond the existing literature. That is, you document the impact by the private sector would vary with different type of diseases. That is very, very interesting findings, because in the past research, very few studies go that far. My only reservation for you and for myself too, because I have done similar research to try to show competition does bring some positive things. My only reservation is, in your study, there has to be some selection bias of private hospital location, because think about it. You showed more private hospitals in the area tend to lead a lower cost, but you cannot rule out the possibility that the private investors tend to go to the areas where they may not face much financial pressures, or they might find markets to have better conditions. So that's where the investors would consider before they develop a private hospital. So there is a selection bias from the investment standpoint. How to address that? In your data, obviously you cannot address that. So alternatively, you may think about something like in Suqian City in China, where all hospitals, all providers in the whole city have been privatized. So there's very little selection of the hospitals by the investors. So if you can compare those citywide privatizing of the provider to see how the service providers come out with services that would be, say, hypothetically cheaper, or more accessible, more affordable, as compared to services that are provided in other provincial places, other counties, or even national average. If you can come up with something like that, I think you can somewhat minimize the selection bias. So I think that's the only reservation I have for this kind of study. Okay, so that's all.
I feel I'm the last hurdle for you to get your lunch, so I'll be quick. I'll be really just focusing on the paper that I'm assigned to comment, and 3 issues. First of all, I guess if you look at Asia, there are quite a few models that you can learn in terms of developing long-term care insurance. For example, Japan has its own in year 2000, Korea 2008, and in between there's Singapore, which is slightly different, but still is a disability insurance program in year 2002. And so these 3 countries provide valuable lessons. By the way, we need access to introduce ourselves. I forgot about that. So Rachel Liu,
professor of health economics and healthcare management at Chang'an University in Taiwan. And I forgot to compliment on the presentation made by Hu Ming, which is very thorough, provides valuable information so that I can make a few comments on that. So, that's the first thing. There are models in Asia to learn from. And the second thing is, when you look at these countries, you will notice that there's an undersupply of long-term care services to begin with. And one of the important lessons to learn is that while you're doing the pilot study, I think it's a golden opportunity to invest in educational programs to cultivate locally the service human power or human capital. And so I think when you do the pilot and you realize there's an underservice, and like I say, it's really golden opportunity. And a few steps to do that, usually people will start from educational program because that's how medical professionals are cultivated. So that's number two. And in the presentation, Hu Ming also raised a few questions, particularly financing issues, which is really critical for long-term care insurance. And I wish Taiwan was able to offer any experience, but unfortunately, my government spent 8 years in planning for long-term care insurance. But when the government changed hands in 2016, the new government, PPP, decided to take a different route. So now we actually have a tax-funded long-term care services, what we call long-term care 2.0. That substantially reduced the estimated budget to 1/4. So it was estimated like 4.3 billion if we have a long-term care insurance model. That's the estimated budget, but literally the government is only spending $1 billion in long-term care services at this point. So financing is crucial. And I think for the financing part, for long-term care insurance to be sustainable, it has to be earmarked tax. So the money, the premium goes to long-term care, but nothing else. So it's really a challenge when you actually ask money from two existing pool, and then there are challenges in terms of how much they're going to allocate to you. And so it's better to have the decision power in your hand. So for that, I think all the social insurance model actually have a tax, sort of earmark tax, whether it's payroll or any kind of tax, but it's earmarked, so it's only allocated for long-term care insurance. In terms of administration, if you think about the Japanese model or the South Korea model, actually they take advantage of the existing social insurance program, namely their national health insurance program. So administration-wise, it's going through, the collecting of a revenue, when you collect revenues, it's through the same administration, so that gives you the economies of scale. It's not like a totally new infrastructure to collect money. But financially, they are two separate pools. So one for national health insurance for acute care and one for long-term care. So that will help them to maintain their sort of financial solvency. So I think that's important lessons to learn from the other countries in Asia, like namely Japan and South Korea. And in terms of pooling the size of a fund, I think it's law of large numbers apply. It's better the pool is bigger than smaller. Ideally, if it's a single pool, that would be even better because that will help you to avoid risk selection, all those moral hazard issues, this and that. So I think those are the fundamental lessons we can actually learn from Japan, South Korea, or even Singapore. And I'll stop that right here.
I'm sorry that I'm aware that we're way over time, and I'm sure you want to go have lunch. And so unless Ajay and Peter has some remaining comments on broader Asia, Southeast Asia that you have been holding back, do you? No. I think we should end the session, and I'm sure the speakers and the panelists will be happy to stay behind if you're interested to ask more questions. And so the session has been videotaped, and if I get consent from all those who have spoken, then we actually would post it on the Harvard-China Health Partnership website in case you want to revisit some of their what they say, and then come back to ask them questions. So thank you very much for coming and your patience.